Thank you very much for that kind introduction. So we'll go through spine MRI a little bit, and just a disclaimer that you heard a radiologist speak, but when I as a clinician look at spine MRIs, we tend to look at it a little bit differently. And no offense, my wife is a radiologist, and I kind of see her reporting these degenerative MRIs, and she spends like 20 minutes, 30 minutes going through the images and does measurements of the thecal sac and these many millimeters and that many millimeters and disc bulge at L1, L2 and this at L2, L3 and this at this, and I tell her this is all useless. because because when we look at it, we don't see all that. And then like I said in the previous talk, it is all about your history and examination. So we all know this is a very famous study. They kind of took volunteers in the MRI, normal people did their MRI scans for the spine, and they found that almost everybody has something or the other as a degenerative change in the spine, and obviously it's related with age. And we also know from today that these are unrelated to symptoms. It's difficult to correlate them 100% because asymptomatic people have a lot of these changes. And we as physicians and clinicians, we think that we do a lot for the patient by giving their disease a name. And we just had a talk at the tea time with someone. I was speaking to them. But when you are in a clinic and when you are talking to a patient and seeing their MRI and explaining to the patient why they have back pain, and when you tell them that, oh, you have back pain because of this facet arthritis, and you have a disc bulge, and you are giving them something to hold on to, you are actually causing harm. It depends on the pain syndrome actually. So if you are treating patients with low back pain that are degenerative and you are talking like this to the patient with their MRI reports or MRI scans, you are actually not helping the patient. So that brings us to indications for doing spine MRIs. So we all know these. There's a big list of red flags imaging when we do red flag signs when we ask for imaging. And the primary thing for low back pain when we ask for imaging is when we suspect that there is something other than a degenerative change that can be responsible for the patient's back pain. You're thinking of infection, fracture, etc. So there's a big list of red flags, and we are asking for MRIs for that purpose. That's one. And the second purpose we are asking an MRI is because your clinical diagnosis is that of a neurological concern. That means you have a radiculitis, radiculopathy, or neurogenic claudication, and you are looking specifically for a correlation with that neurological symptom with the MRI. So these are two broad reasons why you would get an MRI done. Well, there are three things about these red flag signs that you should remember. One is that serious causes of back pain are really rare in practice. Second, that red flags have a very poor accuracy rate. And third, if you image everyone with a red flag, you will have an overdiagnosis, and we'll see each one at a time. So first, serious causes of low back pain are very rare. So if you look at MRIs for low back pain for these 1,000 patients or so who are in general practice setting, less than 1% had a serious pathology. So, and out of these, 80% had at least one red flag that was positive in their history and examination. Most red flags have a poor or untested accuracy, so which means that this study has shown that red flags, when they are present, it may indicate a serious pathology, but if your red flag is absent, it does not rule out a serious pathology. So that's a very important thing to remember, that if there is absence of red flag, doesn't mean that the patient does not have a serious pathology. And then again, obviously, if you image everyone with a red flag, that is going to lead to overdiagnosis, as we have seen. So for every 100 people with the usual low back pain that you see in practice, who gets an MRI scan, 68% of them will get a false alarm. 11 will recover more slowly than someone who doesn't get an MRI. One person will land up with me and I'll do surgery for them that they didn't need. and 0 will be better off. So, you know, you have to be careful about ordering MRIs and then interpreting them for the usual kind of low back pain. So what is more important is to assess clusters of red flags. For example, you know, you have a patient who has prolonged use of corticosteroids. Their chance of having fracture is about 33%. But if you have 3 red flags together, female, more than 70, fragility, like a fall from a standing level, plus long-term steroids. So see, groups, there are many red flags have come together, and then the chance of having a fracture for that patient is much higher than someone who just has 1 red flag. So look at clusters of red flags than just single red flags. Avoid inappropriate use of MRI. So as we discussed in the previous talk as well, history and physical examination is very, very important. It is not recommended to order routine X-rays and MRI. I think this has been stressed a lot. You need to have a working diagnosis before you order an MRI. Order appropriate imaging only and only if it affects your decision making. There is no point in seeing an MRI of someone whom you are anyway going to send to physiotherapy, this and that. It's not going to change the way you will treat a patient. For that person, it is not very useful. Always start with X-rays first, and always ask for standing X-rays. There is no role of supine X-rays for degenerative problems, because this is the only investigation that you can do in weight bearing position, and many of these people have problems in weight bearing. So you want to look how the spine looks or how it is aligned in the standing position. You will detect scoliosis, spondylolisthesis, and different problems with alignment in standing MRIs that you may miss in supine MRIs. We have already seen these MRI signal intensities and the T1 weighted images and T2 weighted images. Broadly speaking, when you are seeing spine, pathology is better seen on T2 weighted images because the CSF is bright, and you see contrast when the CSF is bright because it looks like a myelogram picture. Whereas for T1 weighted images, you see the anatomy much better. So when you are looking at MRI, you should have we look at like a search pattern in our mind. Again, this will be different from how a radiologist will look at A, B, C, D, E, alignment, bones, canal, degenerative changes, and everything else. So alignment, you know, you can have degenerative scoliosis, spondylolisthesis, like this patient has a spondylolisthesis at L5-S1. This is actually a lytic spondylolisthesis. You can see a pars defect on the X-ray. And again, these imaging modalities are complementary. You rarely see MRIs in isolation without seeing X-rays of the patient, right? Because X-rays are much easier to do than MRIs. B is bone. You're looking at the structural integrity. You might detect fractures such as this. You can see that cleft sign is a typical sign of an osteoporotic fracture. And the vertebral body has marrow in it, right? So the marrow has fat, red marrow and yellow marrow. The red marrow is more of the hemopoietic marrow, whereas the yellow marrow is the one that has more fat. And fat appears bright, as we saw in the previous talk on T2 weighted images as well as T1 weighted images. So you see the first image is a T1 weighted image where the marrow appears brighter. So the signal intensity of the vertebral body is brighter than the disc space. This space is fibrocartilage, so it is going to appear more darker. And a fat suppressed image or a stir image, the marrow, the fat is going to get suppressed, so the marrow looks much darker on stir images. And you know, stir images are useful for identifying edema, like you saw in the knee. So that's a very good tool in the spine. So there is always a stir image provided by the radiologist for spine. And then on the axial images also similar thing, right? So you will see that these are normal marrow changes, and as a person ages, you will find that there is more fatty marrow reconversion. The hemopoietic marrow is lesser and the yellow marrow is more. So you will see these kind of a variegated appearance. These are normal marrow changes. These are not abnormal. In all the three examples, the vertebral body signal is higher than the disc space, which is how it should be. Whereas in this example, you can see this is a T1 weighted image. T1 weighted image fat is supposed to be brighter, and you see that the vertebral body, the fat is lower than the disc. So this is some abnormalities. This patient had acute lymphoid leukemia. So these are marrow abnormalities. But the most common marrow abnormality that you will see in a degenerative pathology is what we call as modic changes. So there are 3 types of modic changes: type 1, type 2, and type 3. And the first example you see here is that you are seeing a bright signal in T2, a darker signal in T1, and that indicates edema. Edema will appear bright in stir, so it looks brighter on stir. So that is vascularized fibrous tissue, it's more edematous, and there is more correlation of back pain with type 1 modic changes than the others, where there is a type 2 is a fatty marrow conversion. So in T1 weighted images, the end plate will look brighter, which indicates a fatty change. Fat gets suppressed in stir, so it's going to look, darker. And then the third type is sclerosis. In sclerosis, it will be dark in all the sequences because bone appears dark and sclerosis will appear darker. So that's the third stage where it is more stable. The inflammatory component has gone down. So these are the three kind of modic changes that you would see in different stages of degeneration at the disc space. Again, marrow changes in the sacroiliac region are sacroiliitis like this. You can see inflammatory changes. These are stir sequences. You can see inflammation, bright signals here. Again, that's a differential diagnosis of back pain. So always get your MRIs, the axial sequences should go into the sacral region. So make sure that you tell your MRI, radiologist that when you are assessing back pain, get axial images, because your sagittal images may not always give you that area in the imaging. Although they provide coronal stir images where you can pick this up as well in the screening. This is septic infection, pyogenic infection of the sacroiliac region looks very much different than inflammatory disease where you can see abscess, there is a psoas abscess there. And this is again a differential diagnosis, is a sacral insufficiency fracture. You can see the fracture lines here. Again a differential diagnosis of back pain or sacro. It looks like there is inflammation here, but this is not sacroiliitis. This is sacral insufficiency fracture. C is for canal. There are problems in the canal. First patient has a tumor here. This patient has a tethered cord. Spinal cord is going all the way down. This patient has a clumping of the nerve roots here. That's arachnoiditis. Normal looks like this. These dots are the nerve roots, So again in the canal there is the epidural space. Here there is a lot of fat in the epidural space. You can see all the bright signals around the thecal sac. It is compressed. So this is epidural lipomatosis. There is an epidural abscess here compressing the thecal sac. That's an abscess which is, this is post contrast, so it is enhancing in the periphery. Then coming to the D or degenerative changes in the discs are graded differently with like the Furman's classification. There are so many classifications, but it's just like a progressive change that is described in the disc. So you can see the first disc is normal. Second one, there is a kind of a cleft appearing here. That's the kind of a differentiation between the nucleus and the annulus. Here that thing becomes more unclear. The disc height is reduced. Here the disc height is further reduced and it looks much darker. Any differentiation between the annulus fibrosis and nucleus pulposus is lost. Final stage is the disc settles down. So these are just stages of degenerative changes. This high intensity zone or an annular tear is given too much of an importance that as a cause of back pain as annular tears, but if you see the incidence of these annular tears or high intensity zones in asymptomatic population also, it is quite high. So blaming somebody's back pain on the high intensity zone is not always right. So look at the clinical syndrome and then decide what you want to, how you want to treat the patient rather than telling the patient annular tear, right? Coming to the disc herniation classification, the way of this description nomenclature, like what is a disc bulge, what is a protrusion, what is an extrusion. So what it just means, a disc bulge is kind of the annulus bulges out from all sides. There is no focal area of herniation. It's just the disc is bulging. It's like a car tire losing some air and then it bulges out from all sides. It can bulge out asymmetrically, but it is not focal. any focal point of break or the herniation is called, protrusion on a extrusion is called as a herniation. These are not disc bulges, these are very focal points of disc displacement. If the base of the disc is wider or the herniation is wider than the tip, it's called protrusion. If the base is narrower than the width, then it's called extrusion. All this is not so great to, it's just a description. In the end, you are looking at the clinical syndrome. Sequestration is if the fragment breaks out and goes somewhere else, that's sequestration. That's the third situation where the fragment is gone outward and lying behind the thecal sac. This is a extrusion and this is a protrusion, right? So this base is wider. So these are different ways of describing a disc herniation. Again, remember that this is a clinical syndrome that we are looking at. So we try to correlate with which nerve root this is compressing, and can that nerve root compression cause that kind of pain and that kind of SLR restriction. You are trying to correlate the symptoms. Intravertebral disc herniation is called as a Schmall's node. Again, many patients it is asymptomatic. For some patients it can be symptomatic. Like this, you can see the acute edematous change around that Schmall's node here. This is a FATSAT image where you see the bright edema around that Schmall's node here. So these can be painful sometimes. Then coming to lumbar canal stenosis, here is a typical example of lumbar canal stenosis. You can see the canal compromise at these places here, and you can see this is the cross section of the canal. This is how it normally looks. These are small nerve roots, you know, motor and sensory goes in pair. The white is the CSF, this is the dural sac. With compression, first grade of compression, you will see all the nerve roots together like this, but you can still see some CSF, but individual nerve roots can be identified. You can see that. The next stage, further compression, you cannot see individual nerve roots. They all appear gray. Individual nerve roots cannot be seen. But there is some epidural fat, this triangular pattern that you can still see here. And the last is the stenosis is so severe that you can't see the canal at all. You cannot see the epidural fat, you can't see thecal sac, you can't make out anything. So that's the most severe grade of stenosis. Again, radiological grade of stenosis does not always correlate with clinical symptoms. You can have severe stenosis and not have symptoms also. These are nerve root redundancy signs. You can see all these looping around of the nerve roots here, crumpling of the nerve roots, and this happens because the cauda equina kind of gets crumpled where the stenosis is. So with flexion, the roots go upwards, but they are not able to slide back down below the stenosis, and they crumple up like that. So you can see that this indicates severe stenosis. So this is a myelographic image. You see this is a severe stenosis here, and these all nerve roots are kind of serpentine and in a loop shaped pattern. Foraminal stenosis is another area where nerve root can get compressed. This is how a normal foramen looks like. This is like a keyhole appearance. So there is this nerve root, that's normal. This is the pedicle. This dot is the blood vessel that accompanies the nerve root, and this is the fat around the nerve root. With compression here, you can see that the fat is reduced here. This is reduced here in all four directions. The fat is reduced, but you can still see the nerve root here. And in this last stage of severe compression, you cannot distinguish anything. It looks totally gray. So this is like a full severe compression of the nerve root in the foramen. Facetal arthropathy is also graded. You don't need to know the grading, but just see how normal looks like. This is the superior facet. This is the inferior facet. That's the that's the synovial fluid in the facet joint. That's the cartilage. And with more degeneration, you stop seeing the synovial fluid. The facet joint arthrosis increases. There is osteophytosis around, and in general, the facet joint will look larger and larger, like this, like almost like a mushroom shaped. You can see that on the CT scan also, irregular margins, and this is like osteoarthritis of the facet joints. Sometimes you see these open facet joints like this. This is like just a subluxation or like a moving apart of the two surfaces of the facet joint. This is just indirect evidence of instability, because remember, these MRIs are done in supine position, and in supine position everything falls in place. So if this patient has a spondylolisthesis and the vertebra is falling back in a place, you will have that facet opening up, which will look like this, an open facet sign. And when you get x-rays done or a flexion extension x-rays done, you will see that the vertebral body is moving back and forth. But on a supine MRI, you will see that the facet joint is opening up. Like how you get cysts around the knee joint, you can get cysts around the facet joints as well. And these synovial cysts can be either outside the spinal canal or inside the spinal canal. If they are inside the spinal canal, they can compress on the nerve roots and cause radicular syndromes. And then coming to these all gamut of degenerative changes, you need to understand what possibly could be more clinically important for a person who has that typical mechanical back pain or a degenerative sort of pain. These kind of, the left side can be more clinically important: moderate severe stenosis, disc extrusion, nerve root displacements or compression, end plate edemas that we talked about, or higher grade listhesis. But many of these changes, other changes that we saw, may not be clinically important for a person. So when I look at MRIs, when I'm looking at MRIs for a person with a neurological problem, I'm thinking of the nerve root. I'm not thinking of the disc or the disc herniation or the stenosis or what kind of degenerative changes they have. I'm thinking which nerve root is getting compressed. So you always think which nerve root, and does that nerve root, can it cause that clinical syndrome, is what you are thinking in your mind. You are not thinking ki arey isko ye hai. But the patient can have a sciatica syndrome and have an L1, L2 disc herniation, and then it doesn't match, because that person should have an anterior thigh pain and this. So, so that's the difference between, seeing the description of an MRI and correlating it with your symptoms. So these are the last few slides. So this is the problem with imaging these days, because unfortunately a lot of patients will get MRIs done without prescriptions, because they have back pain, without seeing any clinician. They'll just go to an MRI center, get an MRI done, and our good radiologist friends, including my wife, will nicely report it and write down everything on the report. Patient has an access to that MRI report, so he'll read that report, and that report generates anxiety, right? And some fear in the patient, because patient doesn't know what all these changes mean. And they look up on the internet, and then they get a diagnosis, and that creates like a fear avoidance behavior in that patient. Oh, I have this disc bulge in my L4, L5, I should not bend, or I should not play tennis because I have this on my MRI and I get back pain often. I go to the office, my back hurts, I should give up on sports because I'm going to land up with surgery. And that kind of thing has a poor outcome in terms of treatment, and such kind of patients can easily get convinced for intervention by some unscrupulous, you can call surgeons only, let's blame the surgeons, because they kind of are very happy operating them and doing some interventions, and then you have a failed back syndrome, and then everything goes south from there. So getting these MRI imaging without having a thought process in your mind is just really harmful for a patient. And there have been kind of studies which have said that instead of actually reporting MRIs in the fashion of like disc degeneration or disc bulges or annular tears and fissures, because these are common English words, right? Consider yourself as a layman and then hearing in your MRI report that you have an annular tear, right? Versus if the radiologist report it as a high intensity zone. If the radiologist reports it as high intensity zone, the patient might not get so alarmed about it than reading it as annular tear. Tear means something, damage has happened, like ACL tear. So it is not kind of the same. So I would kind of refer you to this article. You can take a photograph of this. You can go back and read this. This is very important for you as a clinician when you are going to have so many patients with back pain who have MRIs. How do you explain to them their findings? And words really have a very powerful effect on your patients, and they can be a drug and they can be a disease as well. So you have to be careful when you tell somebody that you have wear and tear in your spine, or you have degeneration and you have tear in your spine. So these kind of descriptive terms that you are using in front of your patient for the usual kind of back pain, there are no red flags, there are no other problematic diseases in the spine. For them, these are, so the way I say it, instead of using those words, I say these are normal age-related changes. If we take 100 people like you, your age group, if we do their MRIs, this is how their MRIs are going to look like. We are going to treat your symptoms. You don't have a serious problem. You don't have a disease. You don't have a fracture. So basically your way of describing the MRI to your patient is more of a reassurance. So this is what 99% of your patients with MRIs will be. There are going to be some small percentage of patients who have like the acute radicular pain syndrome or neurogenic claudications, and they have neurostenosis and all. Those guys you can send to me. Thank you very much.